For third case discussion is perioperative Takotsubo cardiomyopathy by Dr. Manohar sir, consultant cardiologist from Aster Ramesh hospitals. We welcome you.
Good afternoon, Marindol. So I'll be speaking about a couple of cases of Takotsubo syndrome, especially pertaining to the periop period, which looks like an MI but behaves like a mystery. So poetically speaking, when ECG says MI but coronary says no, it's Takotsubo. So I'll speak about both the cases and then we can have a couple of questions for discussion. So the first case was a young female, 25-year-old female without any risk factors. 3 years before the current presentation, she had a fall for which calcaneal bone as well as spinal fixation was done. And then she was taken up during the current admission, before to our admission for implant removal in an outside hospital under spinal anesthesia. Patient developed hypotension in the intra-op period for which she was managed with inotropes. But she later on, immediate post-op period, she complained of chest pain and shortness of breath, and also had hypotension again, for which she was treated with adrenaline, noradrenaline and dopamine, and then shifted to our hospital for further evaluation. At presentation to our hospital, she was hypoxic with hypotension, and she had bilateral crepitations with a wet lung, and troponin and NT-proBNP levels were significantly elevated. The ECG showed significant ST depressions in all the leads, with subtle elevations in one AVL and AVR. X-ray, as shown, has pulmonary edema. And echo, as you can see, has severe LV dysfunction with EF of some 15 to 20% with global hypokinesia. Immediately, we have placed an IABP in view of her shock as well as suspicion that it could be Takotsubo. There was transient improvement initially with pulmonary edema, and the X-ray seemingly improved a bit. But by that time she reached our hospital itself, she had multi-organ dysfunction in the view of AK and decreased urine output. Though there was transient improvement of pulmonary edema after IABP, she had worsening of cardiogenic shock and end organ failure with oliguria, and the patient succumbed after day 3. There are a couple of questions pertaining to this case which we'll discuss later. So I'll move on to the second case where again a young female underwent laparoscopic salpingectomy at an outside hospital. She developed class 4 dyspnea immediately after the surgery, for which she was intubated and was referred to our center. Again, she had tachycardia with hypotension and bilateral diffuse crepitations. ECG again showed sinus tachycardia with subtle ST depressions. Echo showed a global hypokinesia with severe LV dysfunction of ejection fraction 25%. Again, similar to the previous case, an IABP was inserted and she was stabilized with intubation as well as IABP. Coronary, gradually her hypotension started improving, and on day 4 of admission, since it was new onset LV dysfunction, and we wanted to rule out a coronary event, and a coronary angiogram was done which showed normal coronaries. Over the period of total 5 days, her tachycardia settled, hypotension improved, and her LV also started improving, and by the time of day 5 she actually had an ejection fraction of 55%, and she was later discharged home walking. So these were the two cases of probably suspected Takotsubo. I would not call them typical cases because they are not postmenopausal females as we typically encounter. They are young females. They had physical trigger, not the emotional trigger, which is traditionally said so. They had global hypokinesia and not apical ballooning. Both of them did not have any elevations. ST elevations are considered a significant thing in Takotsubo, not ST depressions. And there was an initial response to IABP, but unfortunately, since the first case came in a bad shape to our hospital, we couldn't salvage her. So there were, these were the two cases where the presentation was not very typical, but the clinical picture and the overall scenario fits into the diagnosis of Takotsubo. Though we know that premenopausal females account for only 10% of the cases, younger patients actually do have an atypical presentation of Takotsubo with a fewer comorbidities, and they also have more likelihood of having a neurological or psychiatric issues, and these patients have a higher rate of in-hospital complications than the typical Takotsubos do. So we all know the triggers and all. I will not, because of the want of time, I'll probably directly skip on to the cases and the questions. So the questions which we wanted to discuss in these cases are whether an early recognition of these cases versus a delayed diagnosis would help these cases. We all know that the periop event is mostly an ACS. Takotsubo is a rare thing, but one should remember that Takotsubo has a similar presentation irrespective of the age. So every unexplained intra-op hypotension should trigger a suspicion of Takotsubo in addition to the usual acute coronary syndromes. Just for the panel members, we just wanted to know how many cases of ICU or OT related unexplained shock later on turned out to be Takatsubos and not ACS or something else. Any experience with the panel?
Yeah. Once we did a, major procedure in Ramesh Hospital. Of course, she is a elderly lady, around 75, 80 in between. And then we did a, laryngopharyngectomy for that patient because she could not really swallow anything. At the time of surgery, after surgery, she landed in a Takotsubo.
Takotsubo is not an uncommon thing. We see it, I've seen at least 5-6 cases in my life.
Yeah, recently we had one case of a second stage cesarean section who had massive PPH, so intra-op hypotension managed with inotropes. Post-operatively, when we were giving blood transfusion, she had a sudden onset of shortness of breath with aggravation of the hypertension despite being on 2 inotropes. So we were in a dilemma whether it is a transfusion-related reaction or PPCM or something. We did a POCUS, there was global hypokinesia. Cardiologist was called in and he put in a diagnosis of Takotsubo, shifted to the cardiac care. And I don't think an angiogram was done for her, but the cardiac function recovered within 1 week. And as in the second case, she was discharged walking within a week. And within a month, her EF is back to normal.
So just to emphasize the fact that many of us would have encountered cases which are not typical. So Takotsubo probably it's evolving. The entity has been officially recognized only in 1990. So probably we do see a lot of atypical cases which are being missed. So moving on to the second case, one thing which we all know is catecholamines are the cause or the presumed cause of Takotsubo. So are catecholamines worsening the pathophysiology of Takotsubo, or should we really use adrenaline dopamine in these cases? And what do you prefer as the vasopressor of choice in these cases who have shock?
I think one of the important things is that, all anesthetists should know how to do at least look at the echo. And once we diagnose a case of Takotsubo, they call it reverse Takotsubo also is there, where the base doesn't move and the apex moves. So once we make a diagnosis, one of the first things that we do is take off all the inotropes and we use levosimendan or milrinone to offload the patient. That is one of the important things that all of us have to do.
Is there any guidelines to call it as Takotsubo?
Sir, yes, sir. There are multiple diagnostic criteria to say the same, but all of them mandate ruling out any coronary event. Because again, having said this and these all, if you see a peri-op event, it is mostly an acute coronary syndrome. So it mandates that you rule out an acute coronary event by doing a coronary angiogram and rule out that there is no plaque rupture or any thrombus in the coronaries. So having said there are
can't it be a viral cardiomyopathy at that time?
Happening on table is something which is very unusual because they were absolutely normal pre-op.
We will not be damn sure whether it happened on the table or just immediate post-op scenario.
At least both these cases were intra-optic. It would have evolved over time, sir, if it had been a viral myocarditis.
Yeah, there are two aspects of this. One is the definitive diagnostic criterion is cardiac MRI, where you find only edema. There won't be any infarct or fibrosis in Takotsubo, number one. Number two, the catecholamines and all nowadays, I think Dr. Praveen Kumar will be talking about personalized pain management. Hypothalamus pituitary adrenal axis is increasingly being discussed, wherein the glucocorticoid receptors and the mineralocorticoid receptors, there is imbalance in pathology. And when the patients are very anxious, pain, all these areas, now more focus is being done rather than routine opioids and all. So I think sir will be talking, and it's an interesting aspect. About the patients, in fact, I took the history even 4 or 5 years ago also. She was very anxious for 3-4 days even before getting admitted. That's what we got the history. And even this lady, the removal, before that she was quite anxious for 3-4 days. She avoided the doctors. That's what the attendants say.
Higher rate of psychiatric or neurological things are seen in these younger atypical patients. So, with regard to the vasopressors and all, usually it is said that some cases you might not avoid catecholamines altogether, because if there is refractory shock, you will have to give, but at least have a bedside echo frequently and see whether the patient is developing LVOT obstruction. So if the patient is not, then probably catecholamines in a guarded way is something which we can consider. And if there is significant LVOT obstruction, yes, beta blockers and judicious use of IV fluids is something which can be helpful. And the third thing, in both the cases we have put IABP, so probably sir would be the best person to say. So IABP in cases of Takotsubo, what do you think, sir?
Literature doesn't say much, but you know, extreme sympathetic activity, vasoconstriction, it is not a septic shock. So IABP with severe LV dysfunction, 15-20% would definitely benefit to tide over the crisis. As soon as it improved, I think within 24-48 hours we removed it.
Yes, sir.
In Takotsubo with LVOT obstruction, IABP is contraindicated again.
That's what the same discussion we had when we had this. So, see, the patient is admitted in ICU and we frequently do see the echo. So, if the patient is developing some sort of LVOT obstruction, definitely we'll consider de-escalating or weaning the IABP. Till that point of time, yes, there is a role of IABP.
In hyperadrenalism, there will be pseudo LVOT obstruction also. So, it's very difficult to differentiate.
And the last thing to the anesthetist, so we, just to speak, there was an international registry on Takotsubo which says that emotional triggers are the most common. Traditionally it was thought so, but now more and more physical triggers were found to be the most common cause of Takotsubo. So we all know the matrix where every phase can trigger a Takotsubo, where the pain or anxiety can do so. So my question to the anesthetist would be, what choice of anesthesia do you think is safer? If the patient is already a known case of Takotsubo, or in general to avoid Takotsubo, and any specific techniques or tips or tricks in a case who is already known case of Takotsubo?
Can I say something, Suresh? Dr. Ramesh? Dr. Mahesh here. I think a couple of things. One is when we talk about a classical Takotsubo, I think it's basically very centrally mediated. That's a very classical, typical presentation. All those atypical presentations that you're looking at right now, what you presented in a couple of cases, are predominantly probably atypical. I think they're all, in my opinion, I know we can probably group them under Takotsubo, but I think it's predominantly evolving as a stress cardiomyopathy, predominantly, not the classical.
Not the classical ones.
But it is on the myocardial oxygen supply demand issues that are there perioperatively. I think they give a temporary scenario of a cardiomyopathy where the myocardium is completely depressed because of the oxygen supply demand issues. So as an anesthesiologist, it is very important for all of us to understand how do we maintain, even if there is no issue with the coronaries in terms of the myocardial oxygen supply, but I think it's important to maintain that oxygen supply demand, as every anesthesiologist's prerogative have been say very prime importance. It's a prime responsibility for all anesthesiologists to ensure that we maintain those oxygen supply demand in the perioperative period, especially in high-risk cases like what Madam is talking about. We see very often, it's very difficult for us to differentiate between a postpartum cardiomyopathy syndrome, and we see fair bit of LSCS getting into trouble postoperatively. So I think it's important for us to differentiate. It's not easy to differentiate between a postpartum cardiomyopathy or a stress cardiomyopathy scenarios in LSCS. Again, the same issue in LSCS. Very often, suppose if they're coming out from a difficult labor into an emergency LSCS, they are subjected to multiple durations of multiple hours of tachycardia, and then they are coming into the operating room, and then we probably anesthetize them with general anesthesia because there's a fetal distress or a fetal bradycardia. All that scenarios lead to a stress-induced cardiomyopathy. I think it's important for us to maintain the oxygen supply demand as anesthesiologists.
Can we use preoperative anxiolytics? Maybe most of the guidelines may not recommend, but what is the role of, since it is an emotional, one is the most triggering
Dr. Praveen Kumar will talk about pain and anxiety.
So the anesthesia choice, probably it's not the choice which is important, probably it's the principle and how well you do the anesthesia. So I'll just speak a couple of slides. Why is it important to recognize? Because the management is different. You reduce the catecholamine dose if it is a Takotsubo related shock. Watch out for more frequently watch out for LVOT obstruction, and probably you'll consider IABP. And also you unnecessarily will not thrombolyze the patient because the patient most often present with ST elevations. and if treated in time, they have good prognosis. So the key takeaways are, not every peri-op MI is plaque rupture. So ST changes, troponin rise and shock need not be acute coronary syndrome by default. Stress cardiomyopathy is a real peri-op entity. The trigger is iatrogenic in these scenarios, could be emotional, but also iatrogenic. So a smooth anesthesia is something which is very mandatory. And catecholamines in these scenarios are a double-edged sword. And echo obviously beats ECG here because ECG might mislead us into an ST elevation MI. And shock physiology matters more than the label, because treat the hemodynamics first. Probably the labeling of Takotsubo can be done later, because here mechanical support and reduction of catecholamines are more important and not escalating the inotropes. And recovery can be dramatic in most of these patients, and the early recognition salvages the myocardium, and delayed diagnosis might lead to a irreversible damage, just like in our first case where the patient already developed multi-organ dysfunction. Thank you.
Thank you, sir. Thank you, panel members, and thank you.